And I'm going to just share this out on Twitter. If you guys want to look on your pages, it should be there soon as well.
I'll retweet it out.
Yeah. Okay, there it is. Everybody joining, we're going to be starting in just a moment. Sharing this out on Twitter real quick so people can find the link. Okay, that's going out there. All right, we will get started. And then if you guys, I'm going to mute your mics just for a moment, and then I'll unmute them when we get on, okay? Hello, welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA RAPP. I'm your host, Faraj Gupta, and we are back live again for another show. We are excited to be having another ASRA RAPP podcast. I want to thank Ketan Chopra, who hosted the special event that we did a couple weeks ago with all the new pain fellows to cue a question and answer about pain fellowship. I think that was a really useful session. We'll probably do stuff like that, more interactive stuff as we're getting used to this live stream format. But before we get started with today's show, I want to talk about a couple of announcements from ASRA. First off, let me put this up on the screen so you guys can see it. Ooh, those guys are coming in a second here. Let me go back to these guys. And so first thing I want to mention is ASRA has a new app. They just released this, I think, yesterday. It's called ASRA Coder. And it's an effort with some of the chronic pain doctors primarily, but there is some acute pain stuff in here. In this app, it gives you access to kind of filter down through different types of procedures that you'll be doing and find the right code, understand what the Medicare billing for that is, and then maybe suggest some alternate codes. It's a great, useful tool that I think you'll use every day in your practice, particularly our chronic pain colleagues who do a lot of different kinds of procedures and often are responsible for documenting the billing codes. This is available on the iOS store and the Google Play Store, so it's a great opportunity on both platforms. Only $5, and I think it'll be a really useful tool and added to ASRA's already rich app platforms, ASRA Coags, ASRA Local Anesthetic Systemic Toxicity, also known as ASRA Last, and then ASRA Timeout, which is a procedural timeout app checklist. So you can get any one of those on the app stores. Go to ASRA's website to check it out, and you can find all the direct links. Second, I want to mention ASRA's upcoming events. So ASRA has been adapting to the coronavirus world and has done some virtual meetings or set up some virtual meetings. We've already done a couple. We have a few more coming. One on tele pain care, another on back pain. And then the big one is in September, the Ezra and ASRA International Congress. This is a 24-hour Congress that's going to be done all online, and it's completely free for members of both ASRA and Ezra. So if you're a member, you can register for this meeting. They've been collecting the content and the topics, getting all the speakers lined up, and I think it's going to be a really spectacular program. You're really going to get education from across the world, and it's going to be available for a full 24 hours in real time. And then the content's available later as well on to watch back on video. So I just wanted to mention those to you. Pay attention to those upcoming events. The next one is coming up here in just a couple of days. Next up is I want to mention something about the journal. So Azra's journal is Regional Anesthesia and Pain Medicine, and it's been making great strides over the last few years. And so I do want to mention a real big accomplishment. Azra has gone from an impact factor of somewhere in the order of 2 for many years ago, and then it moved up into the 3.5 range, and then 5, and now it's reached 7.015 in the latest ratings. This puts it on par with anesthesiology as one of those two become the top 2 anesthesia journals in the world. So really a spectacular leap forward for this journal. We highly encourage you to submit articles to the journal and read the wonderful content that's published on that on a regular basis. So check out Regional Anesthesia and Pain Medicine. A lot of wonderful, fantastic content coming on this on a regular basis. So going back to our team here, let me get everybody back on, and we will get rid of this for a second. Hey, everybody. Good to have everybody back on. Let me make sure everybody's mics are unmuted, and I want to put your labels on there. Let me get your names as well. Why is that not showing up? Usually, because I got this on, I think. Some reason it doesn't want to show your names. So I'll figure that out as we go. Usually it shows your name right at the bottom. Okay. So what we're going to be talking about. So we have with us my co-host, Eric Schwenk. Eric, how are you?
Good. How are you guys?
Doing very well. And Gary Schwartz is also one of our co-hosts. Gary, how are you?
Doing great. Thanks for having us again, Rod.
Good. And our guest today is Dr. Faraj Abdallah. He's an associate professor of anesthesiology at the University of Toronto and the University of Ottawa. He gets to be at 2 places at the same time. He's also a clinician scientist, and he's the lead author on the publication that we're going to be talking about today. So I'm going to throw this up on the screen real quick. This is the Analgesic Efficacy of Cannabinoids for Acute Pain Management After Surgery. It's a systematic review and meta-analysis from their group up there in Canada. And I think this is going to be an important discussion topic. We have a lot of conversation out in the world about cannabinoids and their value in chronic pain with a lot of supposition and assumption about their value in acute pain. And I think this is an important area of research that needs to be done so that people don't get therapy that's useless or we don't miss out on therapy that's incredibly helpful. And this is all in the context of the opioid epidemic and the fact that we want to try to reduce the amount of opioids people can take. So I'm going to start this off. Dr. Abdallah, welcome. Thanks for joining us. And I'll start off with the first question, which is, what was the inspiration for this analysis, and where do you guys see cannabinoids in your practice that brought up this conversation?
Thank you, Raj, for hosting us and for this excellent opportunity. This question about cannabinoids initially is something that we come across in our clinics prior to surgery when we see patients, and they have some questions about whether or not to continue on their cannabinoids or whether we would be incorporating that into their pain management if they're already using that compound. And the interest in this topic has actually increased with some legislative changes that allowed these compounds to be used without any legal issues around them in Canada and North America. And the question is this going to be the new holy grail of pain management? They have been used extensively in chronic pain management over the past few years, and there is an intuitive assumption that they could also be in acute pain management. So to address these questions, we reflected on the evidence, and not to disappoint those of you who haven't read the paper, I do honestly believe that we're not much further in terms of our knowledge from before in terms of identifying a role for those compounds. What we know now is that the current evidence we have in our hand doesn't really support the routine use of cannabinoids in acute pain management. But this is just a contemporary knowledge, and things could change at any point of time when we have new evidence to influence our practice.
Hey, Gary, why don't you go next with a follow-up question?
This is great. So the hardest thing that the most important thing I was learning about reading the study is that how did you get your methodology? There's so many different dosing regimens and different ratios of CBD, THC. Some were pre-op, some were multi-dose, chronic users. How did you weed out the different studies for your meta-analysis? Because there's not really a single substance. We term everything under cannabinoids or THC, CBD, but there's actually hundreds of different compounds.
Faraj, could you hear Gary okay?
Indeed, there is a lot of heterogeneity in what is being examined here and the approach to incorporating them into the analgesic regimen. And this is very clearly, yes. When we're examining a new compound like that, I'd assume that we are going to use either or a combination of two approaches. First off, the compound is developed in a lab and then goes through phase 1, phase 2, phase 3 trials, or it is put into practice because if it's already there and we have a few observational studies to see if there is a signal, and then once we identify a signal in a certain population, we might go to explanatory trials, clinical trials, and then maybe to pragmatic clinical trials. The problem here with cannabinoids is that it hasn't used any of those approaches in a rigorous way. It seems that the enthusiasm to put this drug or a category of compounds into use has allowed it to have some leaps in terms of use, so jumping stages and not really following a real scientific approach to testing its efficacy. If you're going to examine it in a setting of a clinical trial, I'd rather have one question be addressed at a time. And if we use what conventionally termed as the PICO format, I'd like to see a specific population where I anticipate a significant amount of post-operative acute pain to be involved following surgery, and to have those patients kind of cannabinoid naive to examine whether or not the use would add any benefit. And then when I pick the intervention itself has to be a finite molecule. I cannot pick a compound or a category which has more than 100 compounds in it. So I don't know what exactly is active and what is inactive. And it's more of like a kitchen sink approach. Some of the trials picked a specific synthetic compound that is a cannabinoid and used it. And I kind of favor that approach rather than having a seafood bouillabaisse, I would call it, of compounds that have been dumped on the patients to see whether or not it works. And then we need a clearly defined regimen for administration. We need a specific ratio of CBD to THC. We need a consistent route, and we need to test that in the setting of multimodal analgesia. What's striking is that none of that had happened. And when I compare, I need to have a standardized comparator. I need the comparator to be multimodal analgesia. It is unfair to eliminate components of multimodal analgesia that we use every day to favor cannabinoids and exaggerate their observed effect in these trials. And we also need to have a placebo arm there to account for the placebo effect that we see in pain studies. And the outcomes should be analgesic. We cannot beat around the bush and look at quality of life or functional recovery before we demonstrate the ABCs, the effect on pain, effect on opioid consumption, and eventually I'd like to see some real benefit, not just statistical differences, but clinically important differences when these compounds are used to manage post-operative pain. And until this approach has been used, I cannot give a blanket approval from myself or from pain physicians or anesthesiologists to really incorporate this compound into our standardized multimodal analgesic regimen. So we're still far from that point, and I hope the near future would bring us more robust evidence of its utility.
Thanks a lot, Faraj. This is Eric. I'm asking a question more from the perspective of when you guys were thinking about designing this study. Was this based on what you guys are doing in your clinics? Are you actually giving cannabinoids to any of your patients acutely for acute pain, or are any of your colleagues doing that? And in the studies that you included here, is that what was being done? Or are these patients who are previously not taking cannabinoids at home and are acutely exposed to them for the purpose potentially of acute pain control, or is this people who are already on them, or is it a mix of that? I'm curious, because the idea to me, from what I've seen in my practice, I don't know of anybody giving cannabinoids for acute pain at all. So I'm just kind of curious about the background a little bit, if you don't mind talking to that for a second.
I think we've got a little bit of a delay. Faraj, are you hearing okay?
Canada's far away.
Well, I will disclose that in the settings of chronic pain management, I've put patients on cannabinoids, on CBD, and I am personally curious about its use in acute pain management. But I haven't experienced in person that approach, because I still see that. Yes, I'm hearing you quite well, Raj, and I see the same delay. Actually, I hear your voice. Yeah, I'm actually in the far east of Canada now, and in PEI, Prince Edward Island. So it's a province of 150,000 people, and over the entire COVID period, they've had only 6 cases. That's because by virtue of geography, they close the airport, they close the bridge, they contain the movement. So the downside of that is that communication is a little bit difficult. That's the best line I could find on the island for communicating. And going back to our question, well, Canada legislated or legalized the use of cannabinoids, and we see a lot of patients coming in with the question of, can you put me on cannabinoids for pain management? And my answer would be, well, we don't have the evidence, but if you have chronic pain, the chronic pain specialist might want to do that. Or patients asking, can I start using cannabinoids to help with my pain management? And my answer is usually, well, I think you should keep doing what you're doing. I'm not sure that adding it to what you're taking is going to be beneficial. And if you're already taking it, I'm also not sure if stopping it would be beneficial. I suspect it might be causing some sort of a withdrawal and worsening your post-operative pain management. So the answer to that is keep doing what you're doing, and if you're coming to me for chronic pain management, I'm comfortable using CBD as an option. But if you're asking for acute pain management, unfortunately, the evidence is still not there, and I'm not going to give you something that is unlikely to benefit you, but may have a potential harm.
So before we continue on the conversation, just so everybody knows, we're dealing with a little bit of a delay between Dr. Faraj and the rest of us. I don't know if it's at Canada or just happens to be his internet connection, but so we'll just ask the listeners and Dr. Faraj to be a little bit patient with us as we're going back and forth. We'll try not to speak over each other, but it's about a 10-second delay. So if we're just staring at the camera for a moment, that's what we're doing, just waiting for the delay to pass. I will follow up with a question. The findings of your meta-analysis are one that you obviously didn't find a benefit for cannabinoids in the acute pain process, but there were a couple of other findings that were really important. One is that you noticed a slightly increased amount of pain in the patients taking cannabinoids in the acute 12-hour period. Any thoughts on that? Why that would be?
Thank you, Raj. Yes, this is a kind of interesting observation. The only other time where I found something similar, let me call it rebound pain, was when dealing with regional anesthesia and nerve blocks and the phenomenon of rebound pain following certain interventions that we perform. And I naturally tend to see what the explanation was at that point and whether there were similarities. In rebound pain, usually the simplest explanation is that patients are not very compliant. They have a perfectly working nerve block and they don't think they need anything. So they skip their medications, and then when the block wears off, the pain is ramped up. So that is one of the causes of pain in patients having regional anesthesia. And of course, I also understand and appreciate the possibility of the inflammatory effect of application local anesthetics on nerves. Similarly, I speculate that in patients on cannabinoids, there is also a question of compliance, particularly when what they're using, and if they're already being on those cannabinoids, and the regimen includes some of the THC component, the euphoric component, and the affective component of that might play a role with compliance. And this is probably a oversimplified explanation. The other explanation that we are borrowing from basic sciences is that these cannabinoids, particularly when they're being used in high doses, they have an inhibitory effect on the inhibitory circuits that will eventually result in worse pain. And the worst part of it seems to be happening around the 12-hour time point. These are admittedly speculative explanations. We cannot establish causal.
Oh, it looks like we've lost Dr. Faraj, so he may be struggling with some internet issues here. We'll try to get him back on in just a moment. Hopefully when he gets back on, we may have a little bit improvement in the time delay. Hey, Gary, I'll talk to you a little bit because you've been doing some work in this arena of cannabinoids. Most of your work, I think, is related to cannabinoids in chronic pain. Is that correct?
Yeah, because that's the most common use in the United States. Obviously, what Faraj was talking about is it's legal in Canada, but in the United States, we have a tricky situation. I believe it's 32 states and the District of Columbia, plus some of the different territories have it legal for medical use. 11 states have it legal recreationally. So we have a wide variety of uses in the United States. So I mainly use it in my practice for chronic, as his research shows we don't have great ways of giving it in the acute pain setting, and it looks like it might not even help that much. I was more curious, I'm waiting for him to get back on, because THC is metabolized by the CYP, the CYP450 system. So I wonder if any issue with that, maybe reuptake or higher concentrations are causing the higher pain. Maybe it ramps up the system so they don't respond so well to our post-op analgesics.
Let's see if we can get him back on. I think he's back. Hey, Faraj, how are you?
Hello.
Hey, look, so we may have fixed
Not
our
bad.
time
Sorry
delay.
about that.
We may have
seems
fixed our
that-
delay a little bit too with the
Okay.
new connection. So, okay, I think your internet
Okay.
connection was slowly deteriorating over the course. So let's see if we can do this better. It looks sharper already. So, you were in the middle of your conversation about the 12 hours of pain issues afterward, or the increased pain in the 12 hours afterwards. Eric was going to follow up with a quick question to add on to that. If we want to start with that, Eric.
Yeah, sure. I was just curious. Do you think, Faraj, that the increase in pain was that? Do you think that would have been a result of intentional withholding of opioids by providers in some cases out of fear for side effects like combined respiratory depression of opioids and cannabinoids together? That's probably getting a little bit too deep into the weeds, but I'm curious if you'd speculate a little bit on if that could be the case, why the pain was increased in that group.
Well, one of the problems is we don't know enough. We don't know how much interaction is there between cannabinoids and opioids in terms of the respiratory effect. And when you want to find knowledge on that topic, respiratory depression is kind of a rare outcome. So it's challenging to design a clinical trial to look at that outcome because it's harm. Probably there are ethical concerns to design a study that looks at harm, but also it's a rare one where you need a huge sample size. So clinical trials are not going to inform us about the interaction between opioids and cannabinoids. We probably would want to look at big cohort studies where patients have been using that perioperatively, cannabinoids, and have been put on opioids. And unfortunately, the information available or the evidence available from these cohort studies is very poor and is not sufficient to inform our practice. So we're left to our kind of apprehensive approach to deal with cannabinoids. And some, including myself, when we see someone who is on high dose of cannabinoids, I kind of want to be careful in my opioid prescriptions post-operatively to avoid what I don't know. And lack of information is not the best way to inform our practice, unfortunately. So yes, answering your question, this could potentially be one of the explanations why patients might have rebound pain, and that might probably acquit cannabinoids from being a cause for rebound pain. It would be then our own practices that are being over conservative and not doing a service to our patients in that context. How are we doing with respect to the delay?
Seems much better. Connection just needed a little refresh there.
Gary, why don't you follow up?
Yeah, so in the meta-analysis, we noticed there was an increased risk of hypotension with marijuana cannabinoid use. Any theories on the etiology of this? Is it dose dependent, parasympathetic versus sympathetic? I'd love to hear your thoughts on this.
Again, and this is an area where we can speculate. We know from basic sciences that when cannabinoids are used in higher doses, they tend to have an increase in parasympathetic tone. And that means clinically, the heart is less responsive in situations where it should increase its heart rate, and probably also an effect on the vasomotor tone. So we have less ability to contract the blood vessels, to increase blood pressure in situations where the blood pressure needs to be increased, particularly when we're talking about orthostasis, rising up from a laying flat position or from a sitting down. This delay in the parasympathetic component of the autonomic nervous system seems to be contributing to that phenomenon. That seems to be significant enough to have been caught as a side effect in clinical trials, which is alarming. It means that it is probably more common than we had anticipated with cannabinoids. Mind you, when people are put on cannabinoids in chronic pain clinics, this is one of the things that you hear from them, that I'm feeling a little bit drowsy when I stand up from my sitting position, or when I try to leave bed in the morning. So it is something that we're familiar with, but we did not anticipate in the acute pain settings to be a common side effect, even with the smaller doses that have been used. So one should be mindful about that, particularly when we're dealing with the elderly or those with a higher risk of falls, because we can aggregate additional harmful effects just by increasing the risk for falls.
Eric, go ahead.
Thanks a lot, Faraj. It's something to follow up with. I think it's pretty clear from what you guys found and from what you're saying that at this point, cannabinoids in acute pain really can't be recommended based on the evidence. Chronic pain may be a separate issue, but I think a question a lot of the people listening, and myself included, is what do we do with patients who come in who are chronically taking cannabinoids or are using medical or recreational marijuana? I mean, the number of patients who admit to marijuana taking that during the pre-op interview is pretty substantial, and it's definitely been increasing. So what do we do with that information in the perioperative period? Do we have enough evidence to guide us? Should we cut back on our opioids? Should we, I mean, that's probably a good strategy in general anyway, right? That's what we've been recommending across the board with multimodal and other agents. Are there other things though, in terms of like post-operative monitoring, or what about the patient who's going home the same day? These are the kind of things that I would guess some people are probably wondering about, and I'm curious if you have any thoughts or recommendations based on what you've seen.
Well, it is still an area where we have minimal knowledge, but I'm myself and colleagues as well are cognizant of possible interactions and possible increased risks when dealing with this category of patients. And when it comes to choosing between experiencing a little bit of pain because I'm cutting down on some of the opioid prescription versus having the risk of the patient partying on post-operative day one when they're discharged and then going to sleep and never waking up, I'd take the lesser of the evils and be careful and maybe be more conservative in our opioid prescriptions when we have a concomitant cannabinoid on board. There are some cases where we have heard about patients, unfortunately, having very serious outcomes bad outcomes for being on cannabinoids and having opioids. When there is one kind of substance abuse, there is also usually other kinds of substantive abuse ongoing at the same time. So it is unpredictable, and if there is little control over how much cannabinoid the patient is going to consume, not only because the patient is not going to be clear about it, but also because of variability from the source from which he obtains his or her cannabinoid, then I'd rather to cut down and play it safer on my behalf. And the only factor that I can control is the prescription that I send my patient with, or what I prescribe during the hospital stay. And better safe than sorry in this situation. And I can reiterate, I tell my patients, if you're not on it, please don't start it. And if you're on it, don't stop it, but do not increase what you're taking, because it is not the answer to controlling your pain. And don't go partying after surgery when you are having both cannabinoids and opioids on board. The more serious or dangerous combination seems to be when you add alcohol to this mix, and then we are a step away from some disasters.
Faraj, I'm going to ask sort of a two-part question. One is this question of CBD, which is sort of the medical side, and the recreational THC. Do you see that if somebody's coming in on either of these medications, do you manage them differently as they come in, or do you just assume that you don't have complete understanding of either one of them and you're going to treat them the same? The second part of the question that I would ask is that you've spent some time perusing through lots of studies as you were sifting through for this meta-analysis. And I think that anytime somebody does that, what they're looking for is the perfect study. And so to all the researchers out there, what would you tell them? What's the kind of study that you need? You're sort of alluded to a couple of the points, but what would you like to see in a cannabinoid study for acute pain that would really help you answer the question about whether it has value or not?
To start with, I have my own biases. I've been using cannabinoids in the chronic pain settings. So before going into acute pain, I think we're barking at the wrong tree. And I think I need evidence that helps me get over my biases. The biases is that in my experience with cannabinoids, it's a compound where I start the patient on very small doses and titrate up over weeks, and then slowly add the THC component to address the affective mood. So this slow progressive approach, which is concomitant with some changes at neuroplastic changes with involving the cannabinoid receptors, isn't one that speaks well to the acute pain settings. This is fairly different. We need something that you start immediately before surgery or just after surgery and you see benefit. So I do really need basic science evidence that shows that cannabinoids can act fast enough to address acute pain without having to start the patient on them weeks before the surgery and slowly titrate it up. And that needs really to go back to the drawing board, to basic sciences. And then the other point that I need to be addressed in terms of evidence is that we're not only dealing with pain circuits here. Acute pain has indeed a neuronal circuit component, but it also has the cytokines, the inflammatory transmitters. And what I don't know, or what I don't have enough evidence, is that do cannabinoids really influence in a positive way that component of post-operative pain? That is a big gap in our information. And before both questions are answered, I would still have a lot of hesitancy before promoting this compound for acute pain management.
Faraj, I want to thank you for joining us. We're going to wrap it up, I think, today. This article is fascinating. I'm going to put it back up on the screen for people to look at, because I think this is the beginning of a conversation we're going to be having for a little while. This is in regional anesthesia and pain medicine. I encourage you to go to the journal. It's in the current issue, and read through this article. I don't think it answers all the questions. I think it opens up the conversation to a lot of questions and future research. But I think it's an important start to this conversation. And we get asked this a lot, so it's an important one to consider, especially as patients are coming in more and more on cannabinoids. As we wrap up, I do want to remind people, if there is that there are these upcoming events for ASRA. If you haven't found them yet, if you go to ASRA.com on the events page, if you go to the homepage here, I'll show you. Right up at the beginning, they have a banner, and you can go to the virtual events page and pick any of these events and register for them, and participate in these online virtual sessions. I know all of us are missing the in-person conferences, and we would love to get back to them as soon as possible, but we don't know when that is. And in the meantime, we're doing these podcasts to stay connected, and we're doing these virtual events to stay connected and educated and learning throughout the process. And so I highly encourage you to check these out. And then, as we mentioned earlier, ASRA does have a new app. I'll show you here real quick. It's called Ezra Coder, and it's the brand new app from ASRA for coding your procedures. Great way to look up CPT codes, and then what the corresponding Medicare billing is for those codes for E&M and CPT codes. And the nice thing about this in an app is, instead of a printed document, we can update these in the background. So as new information comes out, the database gets updated and you get the new information. So I think that's a great way to have information at your fingertips that you can reuse clinically. So I want to thank everybody for joining us and for watching on the video. I apologize again for the long delays. Sometimes the internet is not always cooperative with us, but at least we get to see each other's face for a little bit and talk for a little while. And I really appreciate everybody participating. And we will see you guys in about a month. I forgot what date we were going to pick for the next show. Gary, do you remember? I think I told you.
I want to say it's August. I think it's like August 9th, but let me double check. Hold on.
Yeah.
Follow us on social media for the details.
Yeah, that's true. Yeah. So we'll keep posting about it, but well, I don't have it in front of me. It's about exactly a month from now. So we will post more about it as it comes closer. So we're going to try to do this again Sunday evening, 8 p.m. Eastern time. Join us on the live stream. Join us in the comments. Really appreciate it. And then you can always listen to us on the ASRA RAPP podcast afterwards too. We'll push it out as an audio podcast. So thank you, everybody. And thanks for participating. Have a great week ahead. Thank you.
Faraj, thanks for doing all the good work you're doing there.